Thanks very much for the invitation to present on this topic. I'm happy to be part of this conference. I'm going to talk about tendon transfers for upper extremity nerve palsies. These are my disclosures. We use tendons to restore critical functions in the upper extremity when they're damaged by various things. The topic I'm going to focus on today is when there's an unrecoverable nerve injury, but you can use that as a model for almost any other cause of loss of muscle function. The goals in general are to restore grasp, release of grasp, extension of the wrist, and opposition of the thumb. The indications are when we know nerve injury to be irreversible, or when there is partial injury, but with poor recovery potential. There are, of course, alternatives to tendon transfer. Those include bracing in a functional position, retraining other or complementary muscles or functions to substitute for those damaged by nerve palsy, and microvascular or microsurgical nerve transfer. Here are the principles of tendon transfers. So it's important that muscle be selected that is strong enough. And that's because in general, a muscle or a tendon will lose one motor grade of strength in the process of being rerouted and transferred. It's important that it have enough excursion, meaning that the length over which the tendon acts should be comparable to the length over which the target tendon acts. And then it's most helpful if it can be a synergistic action, meaning if you take a tendon and you turn it into an absolute opposite function, that's difficult to retrain and confusing. It's helpful if the transferred tendon can have a direct or straight line of pull. It's important that it be sacrificed for a more important new goal, that is an expendable donor. And it's helpful most of the time if a single function can be performed per transfer. That's a rule we sometimes break, and I'll show you examples of why. When do we do this? Well, after we're sure the nerve is not going to come back on its own. Evaluation before surgery is a critical step to make sure that we understand exactly what nerves are damaged and what the condition of those muscles are. The target joint must have a full or close to full passive range of motion before transfer. And that's because if the reason the tendon seems not to be moving or the joint seems not to be moving is simply that the joint is frozen, well, that of course won't be fixed by a tendon transfer. Then we identify appropriate donors and wait for the appropriate time of transfer. Here's a bit about the technique. It's important to harvest adequate length. And so in general, we take the donor tendon as far distal as possible and then coapt as far proximally as possible in the target. And that gives us just the most room that we can for overlap. There are various ways of coapting one tendon to another. A good one is a pulver-taft weave, and I'll show you a little bit more about that. It's important to make the tension appropriate. One good way to do it is with a tenodesis test, and that is if with resting tension and with the patient asleep or anesthetized, the range of motion of the joint causes the action that we want, then that's an appropriate tension. Either that or just a little tighter than that, because we should expect the tendon to stretch out some after surgery. This is just a diagram of a pulver-taft weave. So the idea is that the substance of one tendon is woven through the other tendon in a crisscrossing way with one passing through the other, and then stitches securing each pass through. In this example, four examples or four passes are shown. Three is often enough. And this is just a recent clinical example of a tendon transfer that I performed inset with a Pulvertaft weave. So that just shows how one tendon is coming through the other, and at each pass, the tendon is sewn in. This clinical example is actually a transfer of the extensor indicis proprius or the extensor pollicis longus, just for simple mechanical rupture of that after non-operatively treated distal radius fracture. That's another good indication for tendon transfer. I'm now going to discuss the three principal isolated nerve palsies and the tendon transfers which are typically employed for each one of those. First, and probably most common, is the radial nerve palsy. Most common because the radial nerve is mechanically vulnerable and very sensitive to irritation or injury, and is quite commonly affected by palsy. What's lost in radial nerve function is wrist, finger, and thumb extension, and there are three very reliable transfers which are described for reproducing those functions. So pronator teres can be transferred to the ECRB for wrist extension, either the FCR or the FCU, either the radial or the ulnar wrist flexor can be transferred to all of the tendons of the extensor digitorum communis for finger extension. And this is one of the exceptions I promised earlier, where a single tendon is used for multiple functions. So in this case, a single wrist flexor, because it's so powerful, can in unison extend all of the fingers at once. And then palmaris longus can be transferred to extensor pollicis longus for thumb extension and retropulsion. This is a clinical video of someone with a partial radial nerve palsy, just to show what it looks like. This patient has some weak wrist function, but no finger extension and no ability to do thumb retropulsion. These are cartoon diagrams showing the transfers I just described. Pronator teres to wrist extension, flexor carpi radialis to the finger extensors, and palmaris longus looped around to perform extensor pollicis longus function. Next, I'll discuss median nerve palsy. The losses here are opposition of the thumb, pronation, radial wrist deviation, and the most common transfers are to take a single finger flexor powered by a different nerve, in this case the ulnar nerve, and routing it to abductor pollicis brevis for thumb opposition, or extensor indicis pollicis, which is radial innervated, into opponent's pollicis. This diagram is actually not one of those transfers. This shows palmaris longus, which is also commonly median innervated, to abductor pollicis brevis, but I an it because it's a very good diagram of how to create a pulley in order to generate an oppositional or thumb opposition force to get the thumb to cross the midline of the palm. It's just an especially good picture of that pulley. And then this is another one showing how EIP can be routed around the hand and then made into a pulley on the pisiform to create a thumb opposition force. And finally, ulnar nerve palsy. This is to restore intrinsic function for key pinch or to eliminate a claw hand deformity. Common transfers are the FDS of the ring to the lateral bands, for example, for a Zancoli lasso, or a wrist extensor to turn into an adductor pollicis for key pinch, which is a critical function of the hand. This video is really just to show what why it is that we prize and prioritize intrinsic function of the hand. So the ulnar innervated intrinsic muscles of the hand permit coordinated flexion of the MP joints with extension of the IP joints. I'll try to show that so you can see. So here's the MP joints extended and the IP joints flexed, or the MP joints flexed and the IP joints extended at the same time. That position is made possible by the ulnar innervated intrinsic muscles of the hand. Without that, an ulnar claw hand like this, the only sort of closure you can achieve of the hand is to pull from distal to proximal the deep flexors and then the superficial flexors of the hand, and it allows only a very small grip. And it's impossible to encompass an object really larger than a very small one. And this video shows just how frustrating it is for a patient to live like this. So she has an ulnar nerve palsy, and she's trying to hold this lightweight, slippery bottle, and she can't encompass it. And the hand just squirts the bottle out again and again. And she underwent Zancoli lasso procedure with good result. I'm sorry, I don't have a video of the result. This shows what the procedure actually looks like. So it is to take an extrinsic flexor of the hand, of the finger, and turn it into a flexor of the metacarpophalangeal joint. So there are no extrinsic flexors of the metacarpophalangeal joints. And so they're only flexed indirectly through the action of the intrinsics. And if the intrinsics aren't working, then it's not possible to encompass a large object. And this rebalances the hand and permits coordinated flexion of the MP while still extending the IP joints. Sometimes more than one nerve is palsied at once and may require several multiple or staged transfers. In general, we try to stabilize the wrist. We try to make sure that we can extend the fingers and grasp, and then fine motor control would come last. The goals of postoperative rehabilitation are first to allow the tendon transfers to heal mechanically, and then gradually to train the patient to use the transferred tendon in the intended way. And this involves usually a prolonged and supervised course of biofeedback and motor re-education. In general, we expect very good outcomes from this, depending on the patient's motivation and the quality of the therapy. Pitfalls are over-tensioning the transfers, choosing donors which are unsuitable either because they're not powerful enough or because they themselves are damaged, or mechanical problems such as adhesions that form in the transferred tendons. So in summary, tendon transfers are a reliable, fairly reproducible way to restore function in a palsied hand. It depends on good choices and then good technique and a multidisciplinary approach, including the surgeon, the therapist, and the patient. Thank you very much.